Okay, thank you for joining the 2023 the Complex PCI meeting. My name is D.W. Park from South Korea. So we're gonna start this year 2023 Complex PCI opening meeting, and I introduce co-moderator Professor Myeong-Ki and S.J. Park in South Korea. We invite the world-renowned panelist, Professor Jung-Min Ahn, South Korea, Kefei duo from China, and Scott Harding from New Zealand, and Do-Yoon Kang, the Korea, and Dr. Ho Ram in Hong Kong, Michael Lee, and the USA, Dr. Yoshinobu Murasato from Japan. So this session will start with opening remark from the Professor S.J. Park.
Good morning, everyone. Today I'm so glad to be here to welcome all of you to Complex PCI 2023. This year is that not only has it's been already 8 years since Complex PCI started, but it's also celebrating 25 years of the main PCI. It seems like a long journey, but I feel like a fleeting moment. There have been many big and small issues and difficulties gone through over the last 25 years. But I think the reason we have been able to come this far is because all the staffs and colleagues have always been with me. I would like to take this opportunity to say thank you all again, our team too. Also, today we have distinguished speakers who make our program even more informative, moderators and panelists who lead this meeting, and attendees from all over the world. Much appreciated being together here and your contribution to the meeting. As always, we prepared insightful sessions which are packed of practical and comprehensive knowledge on interventional techniques. On the first day, the sessions about all PCI are ready from decision making to real practice concern of the main, complex, and CTO PCI. I hope you all enjoy this learning through the expertise to make a procedure simple. On day 2, live cast sessions will be shown all day long, so please stay tuned for the interesting live case transmission from Nanjing Hospital from China and Otakanomori Hospital from Japan, Severance Hospitals, and Asan Medical Center from Korea. I hope you all enjoy, learn from each other, and get inspired by the entire program. Once again, thank you for your supporting. Thank you.
Okay, now we start this session all about the left main PCI. The first topic is a celebration of the left main PCI joint growth and the joining toward 25 years. This topic will be presented D.W. Bang. Dr. Bang, please.
Okay, thank you, Professor M.K. Hong. So today, first opening session is about all about the left main PCI. So my talk is regarding the overall the growth of left main PCI the last 25 years, and then is a future perspective of what the issue remained about the left main PCI. This is my disclosure. So, and two very different procedures available for treatment of left main or multivessel PCI. One is standard the care of bypass surgery is invasive treatment. The one is less invasive, the PCI treatment. So, and this is a slide that shows the over the last 20 years, the milestone about the PCI and the bypass surgery trial, and showing the comparative effectiveness of each other for the left main and multivessel disease and the syntax, pre-combat, and excel and noble trial. So, and the random trial about PCI versus bypass surgery in Asian population is as well, and we published the very important registry and the random trial almost 15 years ago. We first published the New England Journal of Medicine main compare international Korean international registry, and then we published the random trial pre-combat trial 2011 and the 2015. And we published the best trial for multivessel disease regarding the left main and multivessel disease, and the Asian population is work well. So what type of PCI most popular and most famous in Korea, and absolutely, and the rank 1 in the world, and the left main PCI, we have a very long history. We started left main PCI almost 25 years ago. So, and the left main PCI was initially introduced to Dr. Gurunjik, and this is published in Lancet Journal 1978, nearly 40 years ago. And at that time, just to do balloon angioplasty in the left main, the shaft region. So, and in Assam Medical Center, we have also very long history, and this is the first consecutive report of the left main, the PCIs published in JAG 1998, and 42 consecutive and elective patients, and we performed the left main PCI with mainly bare metal stent. This is nearly almost the first report in the publishing JAG. At the time, we showed a very nice demo about how can you do left main PCI. We do rotabulation and then put the Parma shot stent. This is some sort of our history of the left main, the PCI. So this review article is well summarized in published Lancet, and this year, and cardiac surgeon Mario Gaudino is the main author, and in part is bypass surgery, in part in PCI, and the continuous revolution in bypass surgery, open cavity, and Lima and Lima used, and some of the trial was conducted, and PCI and diverse generation drug-eluting stent and short depth, and the adjunctive drug was improved, and imaging guided and FFR guided PCI in both part in the continuously revolution in treatment coronary revascularization. Also, and the medical care was the last 20 years much improved, and in diabetic patient and SGLT2 inhibitor and heart failure patient is ANI, and concomitant antithrombotic P2Y12 inhibitor and high intensity statin. Many medical treatment also evolved well. So, and initially left main PCI and PCI is recommended in just class 3 is not recommended, but over the last 25 years, and the treatment gap, bypass surgery and PCI, much narrowed in accordance of development PCI, bypass surgery, as well as the medical therapy. So I'm gonna briefly look back the PCI versus bypass surgery for left main disease, and some of important trial reported long-term outcome, syntax, pre-combat, noble, excel, and the recent combined IPD meta-analysis. And this is a key summary about the left main PCI, syntax left main, pre-combat trial, excel trial, and noble trial. Primary endpoint and 3 trials shows comparable. Noble trial, bypass surgery was better. And the controversial issue was raised after publication 5-year report in Excel trial. Although primary endpoint all-cause death, stroke, or MI was no difference at all up to 5 years. However, key difference in all-cause mortality was higher in the PCI. There was raised a lot of concern, a lot of debate, and a lot of issue between interventional cardiologists and cardiac surgeon. There was a statistically significant bypass surgery was better better. So there is a cornerstone. We do IPD meta-analysis, including 4 random trials, Syntax, Pre-Combat, and Noble, and Excel trial. This is done independently in the TIMI group, Mark Sabatin, published in Lancet Journal. And the 4 trial up to 5-year, all-cause mortality, no difference at all. And the 2 trial is available, 10-year report, Syntax, and Pre-Combat trial, up to 10-year, no difference at all in all-cause mortality. This is a very interesting diagram looking at the Syntax score category and the low Syntax score and the high Syntax score, looking at the overall cardiovascular mortality hazard ratio. Less than 33 Syntax score is comparable cardiovascular mortality. Over the 33 and the absolutely very high complex, more than 45, bypass surgery was better. And this is a very interesting finding. And the key component of the stroke and the initial time point, bypass surgery is higher, the stroke rate. And the paraprocedural and the spontaneous MI, procedural MI much higher in bypass surgery, spontaneous MI much lower in bypass surgery. So, and the key summary and the last 15 years available PCI versus bypass surgery for left main, no difference in mortality. PCI has a low periprocedural complication, bypass surgery, low spontaneous MI, and repeat revascularization. So, and this is a very nice description. We know where, and the PCI was a better outcome in early period. Bypass surgery is a better outcome in the late period. So, early advantage in PCI, late advantage in bypass surgery. We should concern several things: coronary anatomy, heart team discussion, patient preference, surgical risk, and the clinical presentation, comorbidity, and the life expectancy, and the local expertise. And all combined this condition, we should provide the right revascularization strategy in patients with left main disease. So what about the guideline update? This is the most recent guideline, US guideline. Left main disease, just in the not the high anatomical complex, the low and intermediate, and the PCI recommended 2A. This is a sum of the recommendation, and the not complex left main disease and the not severe combined coronary artery disease, PCI work as a recommendation 2A. So what about the ESC guideline? And after Excel issue, EACTS guideline and the committee withdrawal cardiac surgeon recommendation for ESC, and this is a previous ESC 2018 guideline, and according to Syntax score, less than 32, and the recommendation PCI class 1, 2A, more than Syntax 32, and class 3. This is updated in the last ESC meeting. ESC EACTS is the overall guideline is downgraded, and this is released in the ESC simultaneous publication of the European Heart Journal. This is a joint ESC EACTS review about the previous guideline, and they summarized the overall available the result. They emphasized the IPD meta-analysis published in the JACC. They shows the descriptive finding, and over the 5-year overall event, 20% occurred in PCI group, 16% occurred in bypass surgery group, 89% arrived at 5-year PCI, 90% arrived in the bypass surgery group, and the overall recommendation, just to summarize the 2A, there is no the description about the Syntax score category. This is almost the same, the US guideline. So, and they explained and which factor is a favor PCI and which factor is a favor in bypass surgery. So, and our real practice PCI versus bypass surgery left main disease, and in the what is real practice? So in Assam Medical Center, in the many center in Asian Pacific area, and extensive non-left main coronary artery disease, diffuse and 3-vessel, absolutely bypass surgery was preferred, and the multi-vessel comorbidity are present, PCI is preferred, and the intermediate, low and intermediate risk and the PCI as well as bypass surgery is quite comparable. So what is the next? Left main PCI or multi-vessel PCI? So, and last 15 years, a lot of revolution, imaging-guided PCI as well as a physiology-guided PCI. We routinely use imaging-guided PCI in the complex left main disease and physiology-guided PCI in the several complex disease. And this is a representative case and the visual functional mismatch in the left main disease and angiographically ambiguous and looks like a severe FFR quite okay. This is angiographically quite not severe, just a mild disease. FFR is severely compromised. That is the typical example of the visual and functional mismatch. The reason why that is pivotal that we designed our ongoing the future trial, the main trial. More than 40 Asian Pacific the center will participate our main trial. In this trial, we include more than 900 patients, angiographically diameter stenosis more than 50%, and evaluated one arm is FFR-guided left main PCI versus conventional angiography-guided left main PCI. For both group, imaging-guided optimization was allowed is in both group, and we will evaluate 1 year MACE. So this trial, phase main, would provide the theoretical and the practical concept of a physiology-guided PCI, also work even in left main PCI. We now is the time to start phase main trial, and the overall the complete enrollment we expect 2 or 3 years. So, and the remaining issue about the PCI versus bypass surgery, and the two important part, and ischemic cardiomyopathy, ejection fraction lower than 40%, and the recent revived trial, many stitch trial shows the overall long-term bypass surgery is better, and the PCI do not provide the treatment benefit. This remaining part is contemporary PCI versus bypass surgery in ischemic cardiomyopathy, also in diabetic revascularization. That is mainly based on the Berry 2D Freedom trial conducted in 20 years ago. We now is a much revolution. So, and we need more data. And about the first issue, PCI versus bypass surgery, ischemic cardiomyopathy, Stitch 3 trial is actively ongoing. They are targeting 754 patients, PCI versus bypass surgery comparison trial. Eligible criteria is ejection fraction lower than 40%, multivessel or left main disease, and they do actively random. And 3 and 4 years later, we available to see and the primary comparative result. Also, we designed the defined DM trial is targeting multivessel, and LAD involvement is quite equally PCI versus bypass surgery, and we will random the standard bypass surgery versus imaging and the physiology-guided contemporary state-of-the-art PCI. We evaluated hard endpoint at 2 years, and this trial, defined DM trial, Stitch 3 trial, also provided new evidence about the remained unmet issue. Thank you for your attention.
Okay, excellent summary. We will move the next topic is what really matter in the left main bifurcation PCI concept or the technique. This topic will be presented Professor Park.
Thank you. Great. Anyway, I'm very exciting. This year is 25 years celebrating the main PCI. Okay, what about the current status during the last 25 years? Just DW mentioned about the ESC, syntax scores, lowers, intermediate, clear, class 1A or 2A class, and just shown up meta-analysis in the 4 randomized studies. All there's actually no difference at all. Stroke initial 1 year randomized analysis is a little bit higher in a group bypass surgery. However, no difference at all. Procedural MI, higher bypass surgery, spontaneous MI, higher PCI. Right, exactly the same. 2021 ACCH guidelines, they separate with depending on a high anatomic complexity. So we have to think about that one, right? And then if suitable anatomy, suitable candidate for surgery, why not? Class 1A, bypass surgery. However, not suitable candidate for bypass surgery, very subjective concern, right? The PCI is class 2A. We can say that it's just a simple lesion or very much complex lesion. So we have to do the PCI as a supportive, a treatment tool. Anyway, during the last 25 years, lots of changes. Main disease is not surgical disease anymore. So at the least 2 to thirds of the main disease patients would be candidate for bypass surgery, right? Exactly the same message. Extensive non-name main disease. Syntax score, high syntax scores more than 45 based on the Excel study, you know that bypass surgery may be strongly preferred. Multiple comorbidity status, PCI may be strong. But look at this. What does it mean? High syntax scores, even in the syntax studies, many randomized studies, high syntax scores, including concomitant to 3 vessel disease, right? The high syntax scores mainly due to concomitant 3 vessel disease. If so, if you look at the main disease, isolated main disease concern, only the main disease, look at that one. So main disease is very proximal, big vessel, short lesion length. It is really good target for angioplasty. If you got some idea about the safety concern, procedural issues. And so we discussed about the contemporary PCI, physiology and image supported, ischemia guided PCI. So we can say FFR guided decision making to treat or not treat. We have to think about physiology, IBS guided, finally optimization. Look at this, real world. Non-lesion main stenosis, this is our data, it's more than 1,000 lesions. Significant stenosis more than 50% and negative FFR, what do you think? 57%. More than half significant disease and 50% more than angiographic stenosis, more than half is negative FFR. Lots of mismatch. We cannot believe our at least visual estimation concern. And so you know that from 2018, FFR measurement is clear, right? Class 1A evidence. And so we discuss about unprotected main PCI, integrated use of a fractional flow reserve and intravascular ultrasounds many years ago, almost 10 years ago. Ostial sharp lesion subset. DW has already shown up. A little bit tighter stenosis, more than 80%. However, FFR 0.8 something. If you look at the obvious finding, for particular this case, it's really negative remodeling, at least no disease at all. Ostial part of the main. What do you think? Do you want to treat this one? So, no disease and 0.8. It's just cut up here. Look at this. Insignificant stenosis, about 30% stenosis. However, very strongly positive FFR, mainly related with morphology. Plaque ruptures. Minimal luminaire 6.2 millimeter scale, quite big one. And so we said reverse mismatch. So main disease, intermediate ostial sharp disease, 37% mismatches. 26% reverse mismatches, right? What about the bifurcation lesion? This is very old data, and main bifurcation would be more than 90% of a main bifurcation is not isolated, it's combined LAD and circumflex, and so I would say kind of a bifurcation and main disease, a single unit of the disease, and so we can measure still FFR. After the regions, LAD and circumflex decision making should be based on the physiologic evaluation. There is, Hamelius data long time ago. If the main disease has a downstream disease, still 29% of mismatches, 23% reverse mismatches, and so very interesting findings. We have to realize relatively higher frequency of reverse mismatches in intermediate main disease. And so we measure FFR versus minimal lumen area by IBUS. This is all data, just this one. They compare with the FFR 0.75 matched cutoff value of 5.9 millimeter scale. That is our data. We matched 0.8. Osteal-Schaft disease, cutoff value is 4.5. So practical, how do I implement in ARBS and FFR concern? Osteal-Schaft lesion, less than 4.5 millimeters, ARBS MRA is strongly positive FFR, more than 83% sensitivity concern, positive predictable concern is good. If downstream disease, more than 6 millimeter scales, minimal lumen area, absolutely more than 94% negative FFR. And so between the two, we have to consider FFR between the 4.5 and 6 millimeter scale. So technical issue, simple, very simple stent crossover or two-stent technique. And normal or diminutive circumflex, I would say the size-wise, the circumflex is less than 2.5, small vessel, so it's just a stent cross. Even circumflex has some disease. And true bifurcation, big vessel, we're going to think about the two, upfront to two stent here. Right. The other side branch concern, if we look at the frequency of fractional myocardial mass more than 10%, diagonal branch, obtuse marginal branch, any side branch actually, less than 20%, more than 10% of fractional mass. However, main disease, circumflex would be more than 90% of cases, large ischemic areas, more than 10% fractional mass, 10% fractional mass. And so there are circumflex disease, circumflex artery disease is big enough to treat, and so upfront two-stent technique would be safe. We can avoid the risk of side branch closures, clinical outcomes of a two-stent really good. Even we tried the two-stents from the beginning. Two-stent is better, it's showing Chow's data, DK crush data in the big vessel more than 2.5, and this is our recent registry data. We compare with one stent, two stent for the main disease of all, cardiac death, absolutely no difference at all. A little bit higher target lesion vascularization, target lesion failure. However, we didn't find a statistical difference. All right. EBC main trial, you've known that. 1 year data, they clearly, all right, provisional one stent would be good. However, this year's at 3 years data, Hildick, Smith, David presented the data. No difference at all. Provisional versus systematic two stent. However, TLR rate was significantly lower in provisional stent, 8%, 14%. Most of these repeat intervention occurred in the circumflex ostium. They really, see that circumflex ostium would be problems. However, all right, I don't know, it's my personal issues, and they have no idea about the, image and physiology concern. So it's my, personal opinion. Main remaining issue seems to be TLR of circumflex ostium. Look at this. I will show some cases, true bifurcation disease, and actually some disease on the LAD and proximal side. And we did just single stent crossover. All right, good, perfect result. However, circumflex ostial part, usually they are a little bit ambiguous, findings. Look at this. We have to realize there are many mismatches between the morphologic circumflex compromise and function, FFR. If you look at this, very narrowing, more than 80% has some, diffuse disease, all the situation, all the cases are negative FFR. Actually, if you look at some data, significant circumflex jailing, even you have a very tight stenosis, very significant stenosis, only 7% has a, functionally positive circumflex ostium. So if you do touch, may increase TLR. If you do that, negative FFR, actually that's an hard endpoint concern, no difference at all. And so I would say, even tighter stenosis of circumflex ostial part, negative FFR, actually, don't touch. If they have understanding about the mismatches concern, lots of mismatches in circumflex ostium, and there may be no choice but to treat based on the angiographic ambiguity. And so I would say they have ideas. If you have ideas, any mismatch concerns imaging and physiology, we can, anyway, they can avoid unnecessary procedures, circumflexosity, right? So I would say main issue is TLR from the circumflexosity, right? However, you got some ideas. There are more than 90% mismatches with the morphology concern and FFR. Clearly, we can avoid unnecessary procedure, right? Obviously, optimization concern, they got no idea. So I would say, whatever you use the two-stent technique, the only important practice for clinical outcomes is post-stenting minimal stent areas. Almost 10 years ago, we published our data. 9 months of research said according to the lower, less than 5%, something like that, 5, 6, 7 millimeter scale after two stent. However, recent published data, if you look at the 5-year long-term measure rate, okay, getting the, the bigger the better, 6, 8, 12 millimeter scale in the main. Actually, based on the data, the TLR less than 5%, barely lower. So there is in detail. All right, I'll just skip this one. Anyway, the bigger the better. I've studied is clearly benefit for the survival. Main compare 10 years clearly demonstrate the composite of death actually clearly better in IBSCID. The recent published, European registry data clearly demonstrate survival better survival in imaging guided. And so we can clearly say that IBSCID main PCI had a survival benefit. Upfront to stent, there is very critical examples here, very tough calcified region. Look at this RAD main and circumflex. So we did predilations, kind of a stent crossing here, and then main branch stenting. All right, I would like to show final kissing balloon inflation. So we got very good angiographic findings and aerial view. Finally, minimal lumen area is quite big, enough for the long-term outcomes. So, concept and technique, main PCI 2023, imaging and physiology guided PCI can improve clinical outcomes, definitely. Upfront to stand for true bifurcation and main disease is really safe and good. And so we're going to start the FATE main trial, just a detailed mention about that. Thank you.
Okay, excellent presentation. The final presentation is the precision in the sensitizing insight from the imaging guided left main PCI. This topic will be presented Dr. Han. Dr. Han.
Thank you, Dr. Hong. I'm Jung-Min Ahn from Asan Medical Center. My topic is precision in sensitizing insight from imaging guided left main PCI. First of all, I'm sorry to say that I give you many numbers. So precision means the numbers in science. So critical decision in left main is to stent or not to stent, or provisional or to stent technique bifurcation, and how to optimize. The first, how to determine the significant left main disease. The FFR itself is not easy to measure, particularly if there is the downstream disease. Previously, the two studies demonstration that the FFR matched the IVUS minimal lumen area. Western studies show that the minimal lumen area cutoff value was 6. Our center's Korean data is 4.5. Particularly 4.5 has a very high positive predictive value to predict the FFR value less than 0.80. So if IVUS minimal lumen area in left main is less than 4.5, means the mostly positive FFR value functionally significant. So similar concept to the SJ Park, I'd like to suggest to you that if minimal lumen area of left main is less than 4.5, significant, more than 6.0, insignificant, between, actually we need the FFR measurement or non-invasive functional study. The next issue is which need provisional or two-stent technique. Actually, we don't have good definition who need two-stent or provisional. But even in the random trial, the DK Crush 4-5 trial, EBC main trial, two-stent result is different, opposite. DK Crush 5 trial favoring the two-stent technique. EBC main is favoring the simple crossover stenting. But interestingly, DK Crush 5 study, two-stent technique, 45% in provisional group finally received the two-stent technique. Even in EBC main trial, 22% of patients in provisional stent group finally received the two-stent technique. So certain proportion of patients have to have two-stent technique upfrontly initially. Even in the random trial, the 50% to 30% of patients receive two-stent technique. So the suggested criteria is definition criteria by the Shaoling Chen from China suggested some angiographic criteria. According to angiographic criteria, if the complex bifurcation lesion, two-stent technique would be better than simple crossover stenting. But this is angiographic criteria, but so far we don't have any intravascular ultrasound criteria, but we can guess. This is a simple after simple crossover circumflex FFR result. If a simple crossover circumflex FFR is lower than 0.80, the patient clinical outcome worse than patient with a circumflex FFR more than 0.80. So previously, S.J. Kang, our center, has published data that the incidence of FFR value less than 0.80 after simple crossover stenting. Even though angiography jailing occurred 42%, but the functionally jailing is occurred only 7%. What is the imaging predictor of functional jailing? The one is minimal lumen area at the circumflex ostium less than 3.7. Plaque burden is more than 56%. One very important aspect is a very high negative predictor value. If minimal lumen area is more than 4, if plaque burden is less than 50%, functional jailing is very rare. So I think this is a very important concept, but patient number is only 43. So now we are looking at our larger data to redefine this value in our prospective registry. Then another concept is how to optimize, particularly two-stent technique. Two-stent technique is necessary in some significant proportion of patients. Previously, S.J. Park already mentioned that our criteria 5, 6, 7, 8 criteria, so published by the Seung-Jung. But this criteria based on the heterogeneous stenting technique, two-stent, simple crossover stenting. In addition, this cutoff value validated against the 9-month instance restenosis. So last year, in addition, another criteria, extra criteria show that the larger than previous 5, 6, 7, 8 criteria. Spanish data also different criteria. So last year, we analyzed our data and we tried to redefine this cutoff value, minimal stent area cutoff value, particularly for two-stent technique patient, particularly the crush technique. So we've defined we defined 3 location: proximal LAD, ostium, circumflex ostium, distal left main stenting. So this is the distribution of minimal stent area. The median value of the circumflex ostium is 5.8, LAD ostium is 8, the distal left main is almost 11. So, but the distal left main is not associated to patient outcome, but the LAD ostium is a significant associated patient outcome. Cutoff value was 8.3, circumflex ostium is 5.7. So according to this cutoff value, LAD ostium 8.3, circumflex 5.7, patient composite endpoint MACE is significantly different. There's all-cause mortality also significantly different, particularly circumflex ostium. So circumflex ostium, particularly make a larger stent area, is very important to lead to the favorable long-term outcomes, particularly in patients to receive a two-stent technique. Bigger would be better. So we make a grouping according to the each location's under expansion or full expansion. If there is a 2 under expansion, LAD and circumflex, the patient outcome is worse. But 1 under expansion showed the favorable outcomes regarding the MACE and all-cause deaths. So if you avoid the both under expansion in LAD and circumflex when you implant the crush technique, so patient would be long-term good outcomes. 5-year mortality rate is only 1 or 2%. MACE is only around 5%. Very nice 5-year long-term outcomes. Myocardial infarction is very rare, and target lesion revascularization is only 5%. Then next issue is how to optimize the simple crossover stenting. Compared with the 2-stent technique, conventionally, we thought that the simple crossover stenting may have a lower event rate. So this year, we are looking at our registry, 879 consecutive patients with left main bifurcation under treating using simple crossover stenting in our center. We also measured proximal LAD, this left main, and proximal left main stent minimum stent area. The primary endpoint was the 5-year MACE. So this is the mean stent area of the LAD ostium. LAD ostium, this is the left main and proximal left main. Compared with the 2-stent population, LAD ostium median number is similar, but this left main is smaller than 2-stent technique. So 8.5, 9.9. Left main ostium was 11.6. So how about the proximal left main stent area and clinical outcomes? Proximal left main stent area was cutoff value of 11.6, very significantly different according to the larger compared with the smaller minimal stent area. But this left main, similar to the bifurcation stenting, 9.9, but no difference. But LAD ostium, 8.5, minimal stent area, LAD ostium, larger and smaller, significantly different 5-year MACE rate. So this is new IVUS criteria for left main bifurcation stenting. Provisional stenting, LAD ostium 8.5, this is left main 9.9, left main proximal portion is 11.6, 2-stent technique 8.3, 5.7, around 12. I'm sorry that very many numbers, but I cannot remember all numbers, but I'd like to say that it could be a benchmark. I think 5, 6, 7, 8, this is enough to remember. So I want to suggest this number. This could be a benchmark for more optimizing stent result. This is my summary. Intracoronary imaging has an important role in left main PCI, including decision-making in revascularization, particularly less than 4.5 you can do without additional functional study. And bifurcation stenting strategy, we need more data we are looking at. We can show you the next year complex PCI and final optimization, the 5.5, 6, 7, 8 criteria. Recently, the bigger minimal stent area associated with the better outcomes. I want to say, imaging itself is not associated with better outcomes. Additional effort for more optimizing stenting. If there is under expansion, additional high pressure, or some dissection, or more stenting, based on the coronary imaging may lead to the better stent and patient outcomes. Suggested number could be just a benchmarker for the favorable long-term outcomes. Thank you for your attention.
Okay, very excellent. And it's time to the discussion for the excellent 3 topics. Any comment?
Dr. S.J. and Dr. Duk-Woo Park. In the 5-year data from Excel that was published in New England Journal, in the sub-study analysis, the only predictor where PCI did better was to be stratified by location. So if you had PCI done in the US, it's actually significantly worse with PCI. If you look at European site, there was equipoise. But the other, that would be Asian population. In fact, I saw that your site enrolled 15 patients as part of the Excel trial. The other group, which includes Asians, they're the only patients that actually did better with PCI. Can you explain why perhaps Asians do more imaging? Any thoughts about why there's such a discrepancy with North American or European outcomes, with better outcomes with PCI?
So so first speaking about I think overall available Excel and Noble trial and just the Asian population is less than 10%. So looking at the available data, absolutely, as you mentioned in the clinical trial performed in the Asian population, like a pre-combat and best trial, we are more frequently used than the IPUS image-guided PCI as a routine. Absolutely, I think that is occupied some part is a better outcome in the Asian population. Also, remaining issue about the ethnic difference in the Western population and the Asian population, and we think about the East Asian population is a much benign the patient subset rather than Western population. There is some sort of explanation.
When the left main patient in the Western world, many of the patients have the extensive disease in the LAD or circ. In Asian patient is we frequently or sometimes meet the only confined to the left main and the proximal LAD circ. It may depends on some nutritional or the dietary pattern. What I mean is that what is the incidence of the obesity in the United States? So 20% or 30%. So many of the population is also obese. It means that many of the population have a potential for the atherosclerosis. Is different from the Western and the Asian population.
I'd just like to make a comment.
Agree.
I think one of the really important things is actually operator volume, right? And if you looked at the Excel trial, if you looked at the outcomes between centres, they were very different even within the US. And we know, for example, in Asian, you have a very high volume operators doing a high volume of left main. Many of the operators in the US, even from big centres, are doing very few left mains a year. So all the data shows that the more you do, the better you get, and I think that is a major factor.
Definitely, I agree. Terms of experiences, personal experience, very important. However, if some procedures should be generalized, and so we have to think about contemporary PCI, image guided, IVS guided. However, I just data analysis from the EBC data, even they use the operator, as an operator discretion, they use the imaging less than 40%, something like it. Didn't find any difference, even in the main disease and multi-vessel disease. And so I personally think they really got no idea. So we got lots of data in terms of IVS optimization in your treat or not treat concern. Even you look at some, in detail, actually main issue is the circumflex ostium, TL or something like that. However, I've shown that the data, circumflex ostium, really large proportion of patients had mismatches. Actually, so if some operator had some idea about the FFR and had no idea about FFR, totally different in terms of make some study. Basically, I believe it'll be different with ethnic. Western people had a more diffuse atherosclerosis, more diabetics. I know that. However, main Stent, I've shown just one slide, high syntax score. Even in the Excel study, cutoff value is 45. The meaning is high syntax scores, including more than 65% of patients 3-vessel disease. It is another totally different issue. If we're going to talk about the main PCI, technically, achievement successfully is great. We're going to have a more easier, to proceed a concern. However, multi-vessel disease is a little bit different issues, right? And so any studies combined, main and, confuse the main and multivessel disease, something like that. And so I would say main PCI we can do, main focused main PCI. That's our message, right?
I think it's time to we have to make another new data of the left main. What I mean is that the Noble and Excel was published in the 2015, and then since the 2015 and 16, we have the progress or development of the technique and the drug and the others. So we need the data. And second one is actually the study design should be, we think about that. What I mean is that including the very high syntax score, and then what is the final result? The technically not difficult cases, US guideline 2A, not a class 1. Why? You mean that only as you present in the ostium or in the body, and then left main stent is simple. But by the guideline, it should be first recommended in the bypass surgery, left main disease.
Multivessel disease, actually.
Therefore, the study design should be the very left main oriented. What I mean is with a very simple syntax score. And then we have to prove it. And the PCI is more favorable than the bypass surgery.
Syntax, right? Lots of many kind of syntax scores. Even Patrick published the data. If you look at the main, focused on the main disease, PCI versus surgery, no difference at all according to any syntax score. The meaning is, if you separate main disease, it's quite simple, right? However, issue is combine the multivessel disease, a high syntax score, make some, a disaster according to the, combine the three vessel disease. I think so.
So how do you think about another panel is recently is a left main guideline downgrade in US, even in Europeans 2A. Do you totally agree in the China, the Kefei or Horam is a downgrade, is left main revascularization?
I think it's also need to see the locality, the availability of your cabbage surface. Some area the cabbage surface is underdeveloped, so it cannot generalize to all Asian countries.
Is Kefei, how do you
I think the most important thing is how simple the lesion is and how good you can do it. So I don't think A or 2A is very important. I have a question to Dr. Ahn, a technical issue. You mentioned the post-procedure area very important, but we often meet left main disease with calcified lesion. It's very difficult to open, to expand stent. How can you deal with that situation in left main PCI?
Thank you, Kefei. So actually, this is a kind of benchmark. My suggested number is kind of benchmark. So actually, in our total population, only 50% of patients can achieve that number. This is the first thing. The second, so particularly calcified lesion, I think we need the better lesion preparation. Unfortunately, in Korea, the resorption device is not available, so only the atherectomy device, atherectomy is only available. So, for particularly, even though left main disease, if the very calcified lesion, balloon expansion is not good, so we need atherectomy. Rotablation is first, I think, to make a big stent area. So, but the most left main disease, fortunately, the high pressure balloon dilatation may work. So usually I apply the very high pressure balloon dilatation if there is calcified lesion.
Rota always can't get enough space, so I think IVL may be the future we can use in calcified left main lesion.
Yeah, I fully agree with that. In the near future, I hope to use the IVL in Korea.
Dr. Ahn, just one other question. So you talked about stent size. which is obviously MSA we know is the most important thing. Did you get any insights about whether there are other predictors, for example, did the size of the neocrina, stent distortion, eccentricity, any of these factors make a difference in long-term outcomes?
Yeah, thank you very much. Very interesting question. But yeah, many the operator physicians ask that and have some interested in the such aspect. The angles, the carina, something, the part technique, something like that. But yeah, one study showed that positive, but the other is negative. But I think that what is the most important and strong predictor after stenting would be the minimal lumen area. So that's why we only focus on the minimal stent area only. In addition, such aspect is not easy to analyze.
I just want to add just one more simple number about Dr. Ahn's findings, that the 5.8 for MSA circumflex to obtain, the diameter is 2.75. 2.75 sized or more stent or balloon is the we definitely need for obtain the lumen area more than 5.8. So do not implant more smaller than 2.75 balloon or stent for circumflex ostium. And same for the LAD, 3.25 is good for, is needed to obtain 8 for the LAD ostial size. So do not implant very small stent or balloon, and bigger than 2.75 circumflex, bigger than 3.25 for LAD ostium would be a benefit for the patient. Yes. You know, if we look at surgery in the past 10 to 15 years, how surgery was performed 10 years ago is pretty much the same as it is now. There's been really no innovation. Whereas PCI, we continue to innovate. Before, we used to do it from the femoral artery. Now it's radial, so there's less bleeding. But moving forward, what is the next step where we could optimize results? Is it perhaps, do we limit the number of cases where it's the minimum in order for an operator to do left main? For example, in the United States, there's 1,200 cath labs, but only, let's say, 10%, 20% do TAVR, and that's why you're a part of the TAVR registry or TVT registry. Is there another way to optimize results? Is there a number where we could restrict and say, if you don't do 10, 15 left mains a year, you should not do them because you're not going to get the same results that you see in randomized trial that you get from, let's say, Thorax Center or Asan. Any thoughts?
I've said it. I think numbers are really important. We're fortunate in New Zealand, and that is a public health system. So virtually every operator does a minimum of 100, 150 cases. Most operators are doing 200 cases a year. It's very different to the States. Very different to even Australia. But one of the issues is adoption of intravascular imaging. This is a huge problem in the Western world. You look at Noble, 8% of people had their left main imaged, 8%. We're still having randomized controlled trials of left main where imaging's not mandated. Why? The data is really, really, really clear. We can halve mortality by using intravascular imaging. And the biggest thing we can do in the Western world is adopt intravascular imaging on a routine basis for left main and complex PCI. That's my firm belief. That's what we've been propagating in New Zealand. Imaging rates have gone from about 5% 10 years ago up to 25% over the last 10 years, and we're hoping to get that up to around about 30 to 50%. It's unreimbursed, but it's important.
Okay, it's time to close this session, and I appreciate the 3 speakers and the panelists. Thank you.